All right, so take two. I'll introduce myself if that's.
Yeah, do you feel we should do that?
Yeah.
Okay.
All right, so my name is Juan Cornejo. I'm one of the OBGYNs at Duncan Obstetrics and Gynecology Associates. Here in Duncan, we decided to have a little informal chat regarding irregular bleeding, and we apparently were talking at some length without any sound. So I hope that the sound is back now. So let me just sort of go back and repeat some of what we had talked about. The initial question was, what is irregular bleeding? Irregular bleeding is a very broad term. So when we're talking about irregular bleeding, it can be differences in terms of how heavy it is. So it can be heavy menstrual bleeding. It can vary in terms of how irregular it is. In other words, are you having 2 or 3 cycles per month, or maybe going several months without a cycle? And then finally, sometimes you can have some bleeding in between cycles, which we think of as bleeding or spotting, or postcoital bleeding, which is bleeding after having intercourse. And depending on the source or the type of bleeding, we think of different causes of that bleeding. So, for example, for heavy menstrual bleeding, we often think about things like polyps or fibroids or adenomyosis. For irregular cycles, a lot of times we think about anovulatory bleeding, where you're not ovulating on a regular basis. So the type of bleeding is very helpful for us, or the description of the bleeding is very helpful for us to begin deciding what's the best initial evaluation for a patient, so that we can determine the cause and ultimately, so that hopefully we can help the patient. So what my recommendation from earlier was, if you feel like you're having irregular bleeding, what I would do is I keep a journal for 2 to 3 months. And in the journal, what you want to note is, when does the bleeding start? What day does it end? How heavy is it? You try to quantify it. So, for example, when we think of heavy menstrual bleeding, we think about, are you going through more than 1 tampon an hour for several hours? Are you having large blood clots, say greater than the size of a quarter? Are you having to use more than one method? So you'll hear, I'm using a pad as well as a tampon, and I still soak through. And if you're quantifying it, then that helps us to know whether it's truly heavy. And then the other thing you want to note is, are you feeling lightheaded or dizzy as a result of that bleeding? Which again helps us to sort of quantify how heavy that bleeding is.
I think you got all your hits that you did earlier, so with that. And then the second one, I had asked him about endometriosis.
So endometriosis is one of those mythical concepts that a lot of people talk about. They don't really understand what it is.
Yeah.
And the simple explanation is that it's endometrial glands that are not inside the uterus. So if you look at a picture of a uterus, it has 2 main layers. So the inner layer, which is the endometrial layer, and then the outer layer, which is the muscle layer. So the best way to think about it, the endometrial layer is the one that gets nice and thick and fluffy, waiting for the egg to implant, and that sheds later when you do not get pregnant. Sometimes some of that blood goes back through the fallopian tube and implants into the abdomen. And when it implants into the abdomen, it can cause pain or discomfort as it irritates the things around it. So, for example, if it were to implant in the posterior cul-de-sac, which is the area behind the uterus, a lot of times you can experience painful intercourse, discomfort when going to the bathroom. And generally speaking, the pain gets worse during the menstrual cycle. It's not to say that you only have pain during the menstrual cycle, but generally it's getting worse when as the estrogen levels are getting higher. And that, in a nutshell, is endometriosis, although we tend to ascribe it to a lot of things. That's really the definition. The only way to truly diagnose endometriosis is to do a diagnostic scope of the belly button and get a tissue biopsy and confirm endometriosis. In lieu of that, what we tend to do a lot of times is put a woman on progesterone of some sort, whether it's a Depo-Provera or Lupron. And if she responds to that with the pain getting better, then generally speaking, it's a good bet that she's probably dealing with endometriosis since it's responding to the estrogen.
So then, is there further treatment? Do you have to go in there and try to remove?
Well, generally speaking, the surgical options are limited. So what ends up happening quite often, when we go in surgically, most of us, what we're doing is fairly superficial burning of the implants. Unfortunately, a lot of times those implants go deeper into the tissue, and we don't have the willingness to go that deep because generally those next to vital organs, to truly get a surgery where you're going to get long-lasting results, you're talking about possibly having to do bladder resection, bowel resection, scraping of the peritoneum. There's many very invasive things you have to do to truly get long-lasting results. And the morbidity or the danger from the surgery generally isn't worth it. So quite often our first line of therapy is medical, whether it's something like a Depo-Provera injection, or nowadays we have something like a Mirena, we have the next one on, which are all devices which secrete progesterone to sort of help with the pain.
So is it normal when you're pregnant to spot?
About a third of pregnancies will have some spotting in the first trimester.
When would you be concerned that it's too much?
I think anytime you're concerned, it's too much. In other words, I would always say go get evaluated if you're concerned. That's probably the best rule of thumb. Certainly early in pregnancy, you always have to be worried about a miscarriage, depending on where you are in the pregnancy. The miscarriage rates can be anywhere from 5 to 50%. And, for many women, it gives you some peace of mind to get evaluated and know that you're not going through that process. We also always have to worry a little bit about an ectopic pregnancy, although generally speaking, if you're having an ectopic pregnancy, you'll be experiencing some form of pain. Early on, even an ectopic pregnancy is painless. So having irregular spotting or bleeding, it's never a bad idea to get evaluated.
Okay. If you have irregular periods, does that mean that you could have a harder time becoming pregnant?
Not necessarily,
Okay.
but it depends on why you're having irregular periods. So, for example, if you're one of these women who tends not to have periods, what we call secondary amenorrhea, quite often the cause of that is PCOS, or polycystic ovarian syndrome, and PCOS is known to have infertility as one of its hallmarks. Now, that doesn't mean you can't get pregnant, it just means that it's much more difficult. So if you take the general normal female, her chance of getting pregnant in any given month is about 20%. She's actively trying. Someone with unexplained infertility generally falls down to about 3% in a given month. So, women with PCOS, it's not that they can't get pregnant, it's just that it may take them a much longer period of time.
What would be, or do you know of some of the reasons, besides if it's medical, can stress, environmental factors cause irregular periods?
Absolutely. You see it with marathon runners, where they run hundreds of miles in a week or a month, and their BMI or the body mass gets very low. You see where they stop having periods. You see where women that are severely overweight tend to start having spotting and bleeding. You see it with women when you have a new group of friends. You move, and you have a new circle of female friends where you'll start to sync up with other women and start having some irregular cycles. You'll see it with high periods of stress. Say you're in college and you have finals coming up. Sometimes your cycles will become irregular. So there's certainly a host of factors that can contribute to throwing a cycle off once or twice. And if it's a temporary thing, if it's only happened once or twice, I probably wouldn't worry about it. But if it's a regular occurrence, that's probably going to get evaluated.
You could also help maybe with your journal.
Yes.
When you missed a month or something like that, to journal it or something like that.
Absolutely. Especially with all the little apps that Nike can get on for your iPhone or your Samsung.
Yeah.
Probably 20 to 30 apps that will help you keep track of your menstrual cycle.
Okay, so let's go to the other side where the woman is going through or really has gone through menopause. And I think I read somewhere usually they say you've gone through menopause if you've gone a year without a cycle.
That's correct.
So let's say a woman has gone a year and then all of a sudden she starts not normal cycle, but starts spotting or something like that.
Any woman who has this postmenopausal and has gone through that 12 months like you described and has bleeding should be evaluated
Okay.
With that fail. Even if it's light spotted or bleeding. The main thing that we worry about is endometrial cancer. And the reason for that we worry about it, obviously it's a cancer, but second, it's a very treatable cancer. So generally speaking, if we detect it early in the process, it's very treatable, and your success rates in terms of treatment are very high. Generally speaking, you're talking about a surgical intervention, a hysterectomy being the treatment. If you let it go on for a long period of time and it becomes an invasive cancer, now you're talking about chemotherapy and radiation, and it gets much more difficult. So early detection is key. Having said that, 90% of the time, it's not a cancer. It's something simple like a polyp or a fibroid or an infection causing bleeding. So generally speaking, it's very treatable. I would tell anyone, don't get worried, don't get evaluated.
So going back to the menopause, I think I heard something on TV that there's premenopause and perimenopause and postmenopause. I know this is not all about irregular bleeding, but I think that people would find that interesting. Can you kind of explain the cycle of menopause?
Sure. So menopause is just an arbitrary definition. It's exactly what you said. It's 1 year without a menstrual cycle. Having said that, women aren't like light switches. In other words, it's not that you wake up at age 51, which is the average age for menopause. Someone flicks a switch and your ovaries just stop working. What's happening physiologically is the eggs that you have are the same eggs you had before. So the eggs are becoming less potent. In other words, the function of the egg, every month you release 10 to 15 follicles or eggs, and they are secreting estrogen. As they get older, they're secreting less estrogen. And what happens is that message is going up into the brain, and your brain is sending back something called follicle-stimulating hormone to kind of regulate everything. So you've got this wonderful feedback mechanism. What ends up happening is that estrogen level goes down, your brain says, hey, we're not getting enough estrogen, so it sends more FSH, which is exactly what it says. It says, give me more follicles. So instead of sending out 10 this month, we'll send out 15. So what you'll notice early in menopause, or in perimenopause, is that your cycles will actually start to get a little bit closer. So maybe if you're one of those women that are blessed to have very regular cycles, instead of every 29 days, it's every 27 or every 26. Eventually, as you start to run out of eggs, the cycle starts spacing out. So instead of every 28, it'll be every 30. You may start missing the cycle every now and again. Now, when does that start? We used to say 3 to 5 years before menopause. The literature now says it's probably more like 8 to 10 years before. And it's not unusual women in their early 40s, late 30s will come in saying, I started having hot flashes, I'm starting to experience an increased anxiety. Some of the softer signs of menopause that they're already going through. And that starts fairly early. And as that process, you start running out of estrogen, you start getting more and more of those symptoms. And the dryness, the increased hair in the chin, metabolism slows, all those things that women don't like. And eventually you stop having the periods. And I guess the end of menses is really just the capstone, if you want to think of it that way. It's the end of a cycle. But it's not, there's nothing mystical about it. It's just a natural process that you're going through, and it's a gradual process. Everyone's a little bit different. Some will go through a little bit earlier, some go through a little later. But everyone goes through it, kind of like age. I'll get older.
Yeah, access, everything. Okay, so going back now to the younger women, what would you say to women that are having, I'm just jumping on you all over the place here, but they're having painful intercourse. Maybe there's no bleeding with it, but it's painful. I mean, obviously there's something going on, but I mean, we just don't.
Well, often when it's in the younger woman, you think of infection, right? Whether that's something benign, like a yeast infection, or bacterial vaginosis, or whether we're talking about a sexually transmitted disease, gonorrhea, chlamydia, you have to consider infection as generally one of the prime uh, sources of pelvic pain in your intercourse. So generally speaking, I would say if you're starting to have painful intercourse and you didn't have it before, that would be a reason to come get evaluated.
Okay. So just kind of overall, would you kind of give some ideas of when a woman you feel should contact the doctor no matter what they think is going on in their body? What would be some reasons that you would really suggest that they just don't wait and contact their doctor?
Well, I mean, I think if you're having bleeding after intercourse, I think if you're having postmenopausal bleeding, those are, direct, let's go see the doctor issues. I think if you're having anything that's causing you to have problems sleeping at night, you should probably go get evaluated. Quite often, it's benign things, but what happens is you get on the Google, the great Dr. Google, and you start reading about things, you start getting fears and concerns, and quite often when you have these medical terms, they're very vague symptoms, and it's very difficult for someone to differentiate based solely on a description from Google, whether that's what you're having. I'm not saying that's wrong, because Google has a lot of very good information, especially if you're looking at good reference sources, say the Mayo Clinic, or particular websites that, in my case, the ACOG website, which is the American College of Obstetrics and Gynecology. If you're looking at a good resource-based website, you can actually get very good information on there, and it can help. But sometimes, when we're trying to self-diagnose, we end up scaring ourselves a little more than we need to. And in those cases, it's a good idea to come in and just get evaluated to give you peace of mind. And in those cases where you're right, to get treatment. Right? So if you had a tryst that you're a little ashamed of, and now you think you might have chlamydia, you can sit at home worried about it. You can come get checked, and if you do have it, get treated. Because if it's treated early in the disease process, you're going to get cured, and you're not going to have the sequelae that we normally associate with that. Whereas if you stay at home and you worry about it, eventually it will probably die out on its own. But in the meantime, it could eliminate your chances to have children in the future with scarring of tubes and whatnot. So generally speaking, it's a better idea if you have something that's really concerning you to get evaluated. Just as a general model, I would encourage anyone over 21 to have a good relationship with family practice and OBGYN, where they're getting regular screening for pap smears. Pap smears start at age 21 now. It's every 3 years if it's normal. You would want to get, if you're under age 25 and you're sexually active, probably want to get checked for STDs on an annual basis, since most of those are asymptomatic initially. If you have a good relationship with a doctor, it also makes it easier for you to come in and ask for help when you need it. So whether you're coming in once or twice a year, I think establishing a good relationship with someone that you can talk to and feel comfortable around is a very beneficial thing.
And just for our audience, what is the age for women that they should start having mammograms?
So what I recommend to my patients is starting at age 40, although some places, American Cancer Society is advocating age 45. There are differences of opinion in terms of when is the optimal time. A lot of it is based on false positives. In other words, if you get a mammogram and they say there's a nodule and you get a biopsy and there's nothing from that, because the argument is that you go through a lot of stress and worry during that period of time. A lot of it is based on the cost analysis in terms of, when is it, how many women do you have to do a mammogram in order to prevent cancer. But the one thing that anyone can't get around is that the literature is clear that when you start annual screening at age 40, you detect more women with cancer and you end up saving more lives. And to me, that's the ultimate, which woman is more worried? The woman who has a false positive, needs a biopsy, and then she's relieved, or the woman who had her cancer missed for 3 years because she developed the cancer at age 42 and then gets screened at age 45, and now she's dealing with a much more difficult situation. So I don't think that all worries are even or equal. So I still recommend age 40 as a starting point. I still recommend this.
So it is annual at 40. I thought at one time it was like that's where you get your baseline. And
Again, if you know, there's about 7 or 8 different organizations have recommendations. They're all over the board on that. Some will say biannual, some say annual, then biannual. I think the safest course is probably still age 40 annually until there's a consensus among several of the groups as to what they should do. You look at the Passport guidelines, that's a consensus from the American Society of Colposcopy, but that is joined by ACOG, the American Association of Family Practitioners. So you have several people that have jumped on board that and are all on the same page. So there's very little discrepancy among the different doctors on how to treat HPV and cervical cancer. Whereas with the mammograms, there's still a wide divergence of opinion. So I think when there's a divergence of opinion, I would always go for the safest mode, which is, mammogram is minimally invasive in terms of the amount of radiation you're receiving. It's not comfortable, but if you're lucky enough to come to a place like Duncan, where they have the 3D imaging, it doesn't squeeze quite as much. It's still not comfortable, but it's less. And I think it's a good idea.
I know that at your practice, you guys do the gynecological surgeries and stuff.
Yes.
I think our audience might be interested. Can you tell us some of what you guys do, the different types of surgeries that you're able to perform here?
Well, I mean, I think it's basically across it's a wide variety of surgeries, whether it's doing the diagnostic laparoscopy because someone's having an ovarian cyst or they're having an extreme pelvic pain. We do things like hysterectomies if they're having issues with vaginal vault prolapse where the uterus is falling down a little bit, or if they have heavy bleeding with fibroids, where hysterectomy is the best option. If we do less invasive things like an ablation, so if they're having heavy menstrual bleeding and the best served by just taking care of the endometrium, we do those. We do tubals. I think basically any GYN service we provide, it's really more a question of sitting down with the patient, making sure that we have a diagnosis first before we start operating on someone. Because what I get a lot of times is women coming in saying, "Oh, a hysterectomy because my mother had a hysterectomy, my grandmother had a hysterectomy." And it's important to understand that a lot of these operations, whether they're small or large, have risks. Even if you're the best doctor in the world, you're going to have risks of damaging things or having problems afterwards. So you want to make sure you have a valid diagnosis before you start the surgery. But so generally speaking, what I tell women is if you have a problem or a concern, you should come and get evaluated. And certainly as a part of that evaluation, if we feel that surgical option is a better alternative, we would offer it to them. But in those rare cases where they have cancer, that's where we would refer them to a gynecological oncologist. So really, when you're looking for what's the cutoff between coming to myself or going to a super specialist, when I think of them that way, generally the separation is cancer.
I think we've met our time. So, any key thing you'd like to leave with the audience? To me, like I said in the beginning, which I'm not sure if everyone heard, of course, irregular bleeding is kind of not a fun topic, but it is something that I think almost all women have experienced at maybe possibly one time in their life. But I kind of think of it as not to be ashamed to go to your doctor and talk about it. But is there anything that you'd like to leave with the audience regarding that or anything about a woman's health? That would be great.
Well, I think it just comes back to what we were saying, echoing what we were saying earlier, which is I think it's important for every woman in the reproductive age to have a good relationship with an OBGYN to where they can develop a bond of trust and comfort where you can talk about some of these sensitive issues. Because a lot of things we're talking about are not, lunch conversation. It's generally not something you share with your friends. So it's important to have a relationship where you can trust someone and confide in them when you think something is wrong. But quite often there isn't a problem, but sometimes there is. And it's important that when there is, that we get involved earlier rather than later. And for me, the big issue would be those women that have gone past the age where they have children. So I get, many outpatients who come in and say, I haven't seen an OB in 17 years since I had my last child. And I think that sometimes we forget that there are female issues and problems that extend well past childbirth. So even after you've had a child, I would encourage you to see an OB/GYN at least every 2 to 3 years to make sure everything is okay. Because I have seen some problems where those things get missed, and it leads to downstream problems. Really, it's just finding a doctor you're comfortable with. And we have many options here. We have 3 different OB/GYNs, and we hope that at least one of them will be a fit for them. But even if you don't like any of us, I would still say find someone you're comfortable with, even if they are going to mountain or going to the city or wherever that may be. I think it's important that we have that good relationship.
I think that's really good. I think I agree. A lot of women that after they've had their children, they just don't think about that and life goes on. So I really want to thank you. It was very educational for me. I really appreciate it. We're going to hold up a phone number, an address or phone number for Dr. Cornejo's practice. If you have any questions, please call his office. I'm sure they would be glad to help you. And we'll see you next month for the next DRH Live.